Thank you. Oh, hi, everybody. And thank you, Karen, for making these things always possible and easy for us. Thank you very much. And then, okay, I do hope I'm audible. Yeah. All right. Today is the Monday, the second. We're having the last but one session for the year. And we are going to be discussing irritable bowel syndrome. Dr. Simon Veenstra will be the presenter. I am known as Ramonate. Of course, I think I've been introduced. Yeah, so I have to welcome you all officially. G-ECO is hosted by the Gastro Foundation in association with Project ECO, University of New Mexico. This is for G-ECO fellows and is run every second Monday at 6 o'clock. But however, the few last ones we had to be squeezed over a week at least so that we can finish the syllabus. All right. So in the end, the chat will be open for questions, ladies and gentlemen. So with that, I will ask Dr. Simon to share the screen and carry on. And good luck, Simon.
Thank you, Dr. Ramonate. Alrighty, I just want to confirm that you can see my screen.
Yes, we can.
What?
Alrighty, and I just want to, sorry. There we go. Alrighty. Okay, so good evening, everyone. My name's Simon. I'm one of the fellows at UCT. And this evening, I'm going to be talking about irritable bowel syndrome, something that we've all obviously come across. Just by way of a brief introduction, IBS is a chronic disorder of gut-brain interaction. And it's incredibly prevalent worldwide, with some estimates up to 10% of the global population suffering from IBS symptoms. And obviously it's very common in the primary care setting, but it makes up a large proportion of visits to gastroenterologists. Almost a third of visits are accounted for by IBS. And it has a significant impact both to the patient in terms of quality of life, as well as a significant impact on healthcare systems and cost as well, which both healthcare as well as patient financial cost to the patient as well. And the pathophysiology, which I'm going to get into shortly, is still relatively unknown. There are a lot of hypotheses. But over the last several years, there have been significant advances in that regard. This is just a map showing the worldwide prevalence. It was published in Lancet earlier this year. It's one of the few maps where I struggled to get South Africa included on. But you can see that it's a global issue. There's obviously a lack of data coming from Africa, but locally, we're in the higher proportion. So in the 5 to 10% of patients in South Africa suffer from IBS. So it's something obviously that we see a lot of. When it comes to diagnosis, we use the Rome 4 criteria, which is a sort of a reiteration of the Rome 3 criteria. The diagnostic criteria include, and the most important one being the presence of abdominal pain, with on average at least one day a week in the last 3 months, and it's associated with 2 or more of the following criteria. So it's related to defecation, it's associated with a change in frequency of stool, as well as a change in the form of stool. And these symptoms need to be fulfilled for the last 3 months, but onset of symptoms should have been in the 6 months prior to the diagnosis. And as I've said previously, we used the Rome 3 criteria, which included abdominal discomfort. And the definition in terms of time as well was that it was 3 days per month. So, and that the pain, the other difference includes the pain improved after a bowel movement. So with the Rome 4, the pain is just related to defecation. It can improve, it can get worse, it can stay the same. And there's sort of more days per month included. And when it comes to comparing the two, about 85% of patients who met Rome 3 criteria would fulfill Rome 4 criteria. So it's slightly more specific, but it loses some sensitivity. This is just a sort of colorful schematic of the advances with regards to the pathophysiology in the last few years. And you can see that in the sort of mid-60s, it was thought to be predominantly a motility issue, but really over the last decade or two, the thoughts have been that this is a multifactorial condition with several factors all playing a role in IBS symptoms. And these include genetic and epigenetic influences. So several genes have been identified. These are both polygenic as well as single gene mutations, which have been identified in patients with IBS that are associated with increased abdominal pain. And there's a number of single nuclear polymorphisms as well, or SNPs, that have been identified in patients with IBS. And these account for a broad range of things, but include genes encoding for serotonin signaling, immune regulation, genes relating to epithelial barrier function, bile acid synthesis, cannabinoid receptors. And then there's I think a more increasing knowledge of epigenetics, which is the role the environment plays on one's genes and how these alter genetic expression. And these have also been implicated in IBS. There's several gastrointestinal specific related factors. And this includes things like the gut microbiome, where there's disruption in the mucous epithelial barrier, which allows for an influx of inflammatory mediators. There's changes to the gut microbiota composition, which alters the immunity and integrity. And this alteration also influences the neuromuscular junction and gut-brain axis. And then gut motility issues as well, which is influenced as well by stress, through the 5-HT metabolism or serotonin metabolism. We know that a lot of these patients report an impact that or certain food has on their symptoms. So diet is an important factor in the pathogenesis as well. We know that diet modulates the microenvironment, and can influence gut permeability through that mechanism as well as motility. And FODMAPs, or fermentable oligo, di, mono, and saccharides and polyols also play a large role with symptoms like bloating, abdominal pain, and other symptoms as well in about 70% of these patients. Gluten has also been implicated, even without evidence of celiac disease, but this is somewhat controversial, and I'll discuss that briefly a bit later. And then there's the central nervous system influence as well, with disturbances in the gut-brain axis. And these include things like visceral hypersensitivity, where there have been some neat studies that have shown balloon dilatation in the sigmoid and rectum in patients with IBS. These patients have a much lower pain threshold than your control population. It's also been shown that this gut-brain axis is bidirectional. So, changes in the gut can influence neurological manifestations like depression and anxiety, but stress and can also influence your GI function as well through permeability, motility, and visceral sensitivity as well. So it's really a bidirectional thing and multifactorial. This schematic is also just it's sort of more of a kind of longitudinal picture, but very much sort of repeats what I've said before. Where various factors from birth, including genetic factors, all play a role in the symptomology, which ultimately leads to patients presenting for care. When it comes to risk factors, the strongest associated risk factor is post-infectious IBS, where there's a fourfold increased risk. And patients that are more likely to develop a post-infectious IBS are patients that have concurrent reflux disease or dyspepsia, the severity of their diarrheal illness, whether young females are more likely to develop post-infectious IBS, and whether there's concurrent psychological comorbidities as well, like anxiety and depression, or other stressful life events at the time of the illness, all contribute to IBS or to an increased risk of post-infectious IBS. And the type of pathogen is also important, with your parasitic infections causing the majority of post-infectious IBS, but followed by bacterial and then viral. But there's a host of other risk factors as well. Higher socioeconomic status is related to a higher risk of IBS. Previous antibiotic use obviously disrupts the microbiome, food intolerance, extraintestinal somatic symptoms like migraine, and then some factors that obviously you have no control over. So whether if your mother was very young when you were born, the route of delivery, like cesarean section, increases your risk, and low birth weight babies are also at increased risk. Once we've made a diagnosis of IBS using the Rome classification or Rome criteria, it's important that we then classify the subtype of IBS, and this is done using the Bristol Stool Index. And essentially, the various subtypes include IBS diarrhea and constipation, where you need more than 25% of your bowel motion is either a Bristol 1 or 2 for constipation, or a Bristol 6 and 7 for diarrhea. You have a mixed subtype where it can alternate between the two, and then this unclassified subtype where it doesn't quite meet criteria for either of those. When it comes to diagnosis, traditionally IBS was always seen as a diagnosis of exclusion, but we've moved towards a positive diagnosis, and this is based on a symptom-based clinical diagnosis using the Rome 4 criteria. And what that means is that there's little utility for a wide barrage of tests, and ultimately a positive diagnosis reassures the patient and allows for improved outcomes. And this will be a sort of recurrent theme throughout my presentation. As I've mentioned, and I think this is something that I didn't fully appreciate until the last year or so, was that abdominal pain was a critical component of the diagnosis. And this pain is usually chronic pain. It's usually recurrent and intermittent rather than continuous. And obviously the chronicity allows you to exclude certain, sinister or life-threatening causes for pain. And patients usually report a lower abdominal pain, although this is not sort of a hard and fast rule. And populations, especially the Southeast Asian population, apparently are more likely to report an upper abdominal pain. Once part of making the diagnosis is obviously taking a good history and doing a thorough physical exam. And this is really just to rule out alarm features. On history, we'd be trying to elicit whether there'd been any blood in the stool, chronic diarrhea, whether there'd been any other constitutional symptoms like weight loss, foregut symptoms, if there's a strong family history of IBD, cancer, or celiac disease. A shorter duration of symptoms would obviously point you away from IBS, anemia, whether the new onset symptoms in older age should alert you to something else going on, and then nocturnal symptoms, and if there's been any travel history, especially to a location endemic for parasitic disease. On a physical examination, you'd be looking for things like abdominal masses, whether there's any joint or skin involvement, A digital rectal examination is mandatory, especially for your patients with constipation. You'd be looking for things like blood on your glove or a mass, whether there's any pallor, other features of malabsorption or intestinal obstruction, and any signs of thyroid dysfunction as well. And obviously, if any of those features are present, that would then lead you you would follow a diagnostic algorithm for that. But if it's all negative, then one might consider a few tests. And I think it's, as I've mentioned, it's important to note that several studies have looked at this positive diagnostic strategy versus a standardized panel of investigations like serology, stool analysis, and endoscopy. And that in the positive diagnostic strategy arm, that there have been no extra cases of celiac disease, IBD, or colorectal cancer. In terms of patient outcomes, there's no difference in quality of life, symptoms, or patient satisfaction. And it obviously results in increased costs in the investigational arm. Added to that, there's been a meta-analysis that has looked at, obviously the one condition that one must always think of as IBD, but in any patient who has suggestive symptoms of IBS with a negative CRP and fecal calprotectin, there's a less than 1% chance of inflammatory bowel disease in these patients. So I think a positive diagnostic strategy, both the provider and the patient can be reassured that one is not, missing anything serious. I'm just going to go through some of the guidelines in terms of what they recommend. This is both the American and the British guidelines, which are published in 2021. And so both guidelines suggest or recommend testing for celiac disease in patients with IBS-D. And obviously, this is important due to the long-term sequelae of celiac disease, untreated celiac disease, as well as we know that it is very prevalent, pushing sort of 1% of the population as well. I've mentioned CRP and fecal calprotectin, and this should be done in anyone with alarm features or with the IBS-D subtype. And I've mentioned that the pretest probability of IBD in patients with symptoms for IBS is very, very low. And so it's excellent at ruling out IBD when negative. Routine stool cultures is not recommended in patients with IBS. But obviously, if on history, there's been a travel history or other features that would point towards an infectious cause, then one might consider doing this, especially risk factors for giardiasis. And those would include things like childcare settings, especially in the diaper age, close contacts with someone, and drinking water or untreated water from lakes or rivers, backpackers and hikers, and anyone involved in recreational water activities in where there's been swallowing of water as well, and obviously international travelers. When it comes to endoscopy, there's no indication for routine colonoscopy in patients without alarm features, especially if they're under the age of 45. Obviously, I think the Americans brought their age of screening down to 45. However, I think it is important to note that colorectal screening should be done independent of your IBS symptoms. So someone who's, say, 52 or somewhere along those lines, who's never had a colonoscopy before, that might be an opportunity to then screen for colorectal cancer. The results are probably likely to be negative, and I came across this interesting study by Che et al., where they they actually found a much lower rate of colon polyps in the IBS patients compared with healthy controls. And this was found independent of age, which was quite interesting. So possibly related to different microbiome signatures, but it's just an interesting study. As I've mentioned, the positive diagnostic strategy. So this is supported by both guidelines. And then once we've made the diagnosis, I've mentioned that accurate subtyping is important. This improves patient therapy. Our therapies are also targeted towards the predominant stool pattern. But I think it's also important to note that this needs continuous reassessment, as up to half of patients can actually change their subtype over 1 year. And so it's important to continually reassess this. And as I've mentioned, the positive diagnostic strategies is supported by multiple studies, and it improves patient education and acceptance with early adoption of effective therapies. When there's no routine testing of food allergies and food sensitivities recommended. So up to half of IBS patients will report some adverse reaction to food, but this is not a food allergy. It's more of a food intolerance or sensitivity. And testing is just likely to yield false positives. These tests have low specificity, and so it's not recommended to do that. Anorectal physiology testing is recommended in any patient with a pelvic floor or with a history or examination suggestive of a pelvic floor disorder or refractory constipation, but also important to note that it can occur in all subtypes and has an estimated prevalence of about 40%. And once you suspect this, then a diagnosis requires a positive test in 2 of the 3 tests, and this being anorectal manometry, a balloon expulsion test, or impaired evacuation on dephecography. I'm not sure. We don't have any of these available, but I don't know if anyone else has it available. But yeah, so obviously difficult to, I guess, confirm diagnosis in our setting. But also just to say that this anorectal physiology testing alone may not necessarily differentiate a defecation disorder from IBS, but rather identifies distinct abnormalities that may respond favorably to biofeedback. This is just taken from the guideline and just shows you, I think it's just a nice sort of summary. I'm not going to go through it again, but a summary of the sort of diagnostic algorithm for IBS. So with regards to management, I think the cornerstone of management is really the doctor-patient relationship, and this improves patient quality of life. It's been shown to have, when this relationship is sort of there's good rapport between the provider and the patient, there's a reduction in symptoms, a reduction in healthcare visits, and it's been shown to improve treatment adherence. So what this boils down to is essentially increased empathy, support, and information. Address concerns about serious illness. Patients often feel their complaints are trivialized. And then to understand the life events and stresses. And it's important to communicate a positive diagnosis and management plan. This reassures the patient, and ultimately the aim is to empower the patient to then to manage the symptoms. Regular exercise is important across the board in terms of all subtypes, and assists and improves the global symptoms of IBS. And then dietary therapies are also very important and part of the first line management, and these include soluble fiber, which is important because insoluble fiber may actually exacerbate pain and bloating. And the advice here is to start low, from about 3 to 4 grams daily and build up to about 20 to 30 grams a day. Other dietary therapies include a low FODMAP diet. So I've mentioned the fermentable oligo dye, monosaccharides, and polyols. And diets high in these increase your colonic water and gas production, which results in worsening of symptoms, especially in patients with the visceral hypersensitivity. And it's the one diet with quite a lot of evidence to support an improvement in global symptoms, the low FODMAP diet. It essentially takes place in over three phases. So there's the elimination phase, which takes a course over 2 to 6 weeks. And responders are usually identified in this time frame. And that's followed by a reintroduction phase, and then a personalization phase where specific foods are avoided after reintroduction, after identifying certain trigger foods. But I think it's also, again, important to note that this is quite it's a short-term diet. There's the long-term health risks can be quite marked. It's a very restrictive diet, and can result in micronutrient deficiencies and quite marked changes in the microbiome. And ideally, this should be performed by a gastrointestinal dietitian. The gluten-free diet is quite controversial. There have been some studies that have shown some benefit despite a negative celiac disease workup. But many experts argue that this is actually just due to a reduction in fructans, so i.e. a low FODMAP diet rather than gluten itself. And overall, there's no evidence to support a gluten-free diet for these patients. Excuse me. Probiotics are also one of those therapies that has sort of limited evidence, but intuitively should work. The British guidelines say that it may be beneficial for global symptoms and pain. The American guidelines don't currently recognize, recognize that it is an important area of research. And there's no evidence to support a specific strain or species at this point in time. And then antispasmodics are generally not recommended. There's limited evidence to suggest that they have any significant impact. Obviously, they are widely used, and they do improve some patient symptoms, but overall, their effect seems to be quite limited. But there's, I think there's some sort of pooled data to suggest they work, but in that research, they often include peppermint oil, which I'll get to shortly, and which may sort of sway the results. But I mean, we do use them. I think, obviously in our setting, we don't really have a lot of other medications. And the British guidelines are less, they say that they can be used. The Americans suggest that they shouldn't be recommended. Peppermint oil. So this is one of the first-line therapies. It provides excellent relief of global IBS symptoms. And in a meta-analysis recently done, the number needed to treat to prevent one patient from having persistent symptoms was 3. So an excellent therapeutic effect, and 4 for abdominal pain. So this peppermint oil seems to work very, very well. It had adverse events that were similar to placebo, the big one being heartburn, but there are apparently enteric-coated preparations which may reduce this symptom. And just to say, so peppermint oil, it works by blocking calcium channels with smooth muscle relaxation. It modulates the transient potential voltage channels with effects on visceral sensation, and it has a direct antimicrobial and anti-inflammatory effect as well. So yeah, something to consider. I'm not sure if it's actually available in state, but yeah. Polyethylene glycol is obviously excellent for constipation, but it has no, it's not recommended alone. It doesn't improve overall symptoms or pain. But as I've said, it is excellent in chronic constipation, and where necessary can be used. Then we get onto some of our second line therapies, and these include your chloride channel activators, part of your secretagogue family. So this is lubiprostone, which is a prostaglandin 1 analog. It has a high affinity for type 2 chloride channels, which results in increased intestinal secretion and peristalsis. And it's highly effective for relieving global and individual symptoms. It has a good safety profile, namely nausea and vomiting and diarrhea, but I think it was about 6%, but the discontinuation rate is quite low. So these are excellent second line therapies. Your guanylate cyclase activators are also recommended in your IBS-C phenotype. Linoclonide and plecanatide, they also both effective in relieving overall and individual symptoms. They activate your guanylate cyclase C receptor, and this again also increases fluid secretion and peristalsis. And once again, diarrhea is your most significant adverse event, but thankfully your again patients tolerate it relatively well. Your 5-HT4 agonists, so this is something called tegaserod. It's recommended in a very specific subset of patients. So these are women less than 65 with IBS constipation, who have less than one or less cardiovascular risk factor, and who have failed other therapies. It stimulates the peristaltic reflex and hastens your GI transit. It reduces visceral hypersensitivity. There is a small but increased risk of cardiovascular adverse events. So I think hence the recommendation for low cardiovascular risk patients. Bile acid sequestration. So bile acid malabsorption is also thought to play a role in the symptomology of IBS. But it's not recommended to treat global IBS diarrhea symptoms, although a trial in a subset of patients at risk for bile acid malabsorption can be considered. But overall, it's not recommended. And this subset of patients might be any patient who's at a high risk of that. So someone who's had the terminal ileum or a section of the ileum taken out, or if they've had a cholecystectomy, then these patients a trial might be warranted. One can also then obviously consider, I don't think we have it available, but a selenium 75 test, your SEH-CAT test. Rifaximin is a non-absorbed antibiotic, and it's used to treat global IBS diarrhea symptoms. And this obviously supports the altered microbiome hypothesis. It's incredibly safe. It's effective. It has a number needed to harm of just less than 9,000 compared to a TCA or tricyclic antidepressant with a number needed to harm of 18. And it's very effective. However, 2/3 are likely to relapse, but one can still consider retreatment after that with low risk of resistance. Alisoteron is recommended to relieve IBS diarrhea in women with severe symptoms and failed conventional therapy. So this is a 5-HT3 antagonist, and it slows intestinal transit. It was originally withdrawn from the market in 2000 because of the risk of ischemic colitis, complicated constipation, and even death. And then it was reintroduced on a risk evaluation and management strategy, limiting it to women only with severe symptoms who'd failed other therapies. Ondansetron is also a 5-HT3 antagonist. However, in the Triton trial in 2023, it did not meet its primary endpoints. However, a meta-analysis does suggest that it can improve symptoms like urgency and stool consistency. And the British guidelines say that it's a reasonable alternative, although the Americans don't recommend it. Then we have our mixed opioid agonists, antagonists to treat global IBSD. This is elaxadoline, it's a peripheral acting mu and kappa opioid receptor and a delta receptor antagonist. There is a small risk of pancreatitis and sphincter of Oddi dysfunction. So it's not recommended in patients with a history of pancreatitis or if they consume more than 3 units of alcohol a day. And then loperamide obviously is something we have. It's not recommended as first-line therapy because it doesn't improve your global IBS symptoms. It obviously has a great effect on diarrheal symptoms, but not on your overall global symptoms. Excuse me. And then tricyclic antidepressants should be used to treat global symptoms of IBS. They improve pain due to the anticholinergic effects and central effect on norepinephrine and dopaminergic receptors. And at higher doses, they slow the GI transit and therefore improve diarrhea. And I'll just chat briefly about them at the end again. And then one of the more recent drugs is your sodium hydrogen exchange inhibitor, tenapanor. This improves bloating, abdominal pain, and constipation. It's safe, and its most common side effect is diarrhea. And it works by inhibiting your sodium reabsorption, thereby resulting in increased water secretion and motility, and obviously softening the stool as well. And then, are there any adjunctive therapies? Gut-directed psychotherapy has been shown to be quite effective for global IBS symptoms, especially your mixed and unclassified subtypes. And basically, this is about empowering your patient with techniques to cope with the symptoms. It involves relaxation training, cognitive reframing, and techniques that alter pain reception. And in a randomized control trial by Peters et al., hypnotherapy was shown to be as effective as a low FODMAP diet. It was also safe and had long-term benefits across all IBS subtypes. Intuitively, obviously, with the altered microbiome sort of hypothesis, one would think that a fecal microbiome transplant would be useful, and I think it is still an area of research. However, at the moment, it can't be recommended as there's limited evidence and of low quality. So, as I've mentioned, when we manage these patients, it's directed towards the predominant symptomology. So, this decision tool was brought out by the American Gastroenterology Association in 2022. And basically it goes through the first and second line therapies. And I've obviously discussed a lot of the medication already. So this is really just just a sort of pictorial view of that. Yeah, I think just to point out that they only really recommend your sort of TCAs towards the end of the algorithm with pain. And I think there is probably increasing evidence that, and I'll again discuss it briefly shortly, that this might, that these could probably be brought in earlier to the algorithm. The British one is very similar. I think what I quite like about this one is just how it sort of differentiates the predominant symptom, and how you approach each patient with the various symptomology. They do recommend, as I've mentioned, for abdominal pain as first line your antispasmodics, including peppermint oil, and then for second line your TCAs or your SSRIs, which I haven't really discussed. The Americans don't recommend SSRIs at all. The British are sort of more flexible. And then for constipation, your first line sort of laxatives, and then onto your secretagogues. And then for diarrhea, they do recommend loperamide, and then onto your 5-HT3 receptor antagonists and your peripheral opioid, your mixed peripheral opioid receptor agonist antagonists, as well as rifaximin. So then just quickly, briefly to talk about the central modulators. So this was a review that was brought out earlier this year, and basically just looks at the various central modulators and where they act on the GI tract, as well as what their effect might be psychologically. I won't go through it, but essentially I think this was an expert consensus, and they felt that as gastroenterologists, we should be more comfortable prescribing these earlier in the algorithm to help patients with their symptomology. So in summary, IBS is a common condition. It has a significant impact on the quality of life of patients, as well as on healthcare systems. It's crucial that provider-patient relationship is a good one, and that interaction happens from the first meeting. I've stressed the importance of a positive diagnosis, and how a good history and exam can rule out alarm features. And then it's critical to accurately subclassify these patients to help guide therapy, ultimately allowing us to empower and educate our patients. And as usual, the multidisciplinary team with our dietitians and psychologists are a critical component to the overall care of these patients as well. Thank you. Can I?
Ramon, well done. Thank you very much, and well done. This is a very broad topic, but very relevant, but you've done extremely well on it. Thank you very much. I appreciate it. Hey.
Thank you.
Yeah, so I'm going to say a few things just to make sure that I've understood you very well. I'm doing for myself, right? So, yeah, so the take-home message here, I think, so that we can promote this patient to doctor or the provider relationship, one has to show or demonstrate some form of confidence when you're dealing with this thing, unfortunately. And then if one understands those 7 pathogenic mechanisms, I think it does help. So yes, these 7 mechanisms, which I think it's important for us to understand or to know maybe by heart, is number 1, altered motility has to come in. So whether, especially going to your slowing of the gut, all right, which may lead to constipation, even sometimes pain, but slowing. The visceral hypersensitivity, so that's number 2, so that we can appreciate some centers in the brain which can pick up more of the pain or dysfunction of the gut more in some patients than others. Central dysfunction is number 3. Number 4, low-grade inflammation. Like you explained, some patients may have had previous inflammatory issues, but it's number 4. Then number 5, there's an issue of an entity called increased intestinal permeability, which can be proved in some patients with this IBS thing. I'm not sure whether it's kind of leaky gut, but I'm not sure if it's the same thing, but they're able to prove that. Then there's this big entity now of the disorders of the brain-gut axis. That's I'm putting as number 6. It's a big subject because that's where I think if you're using a Rome 4 classification, you'll see that the specificity comes more, and then of course you lose sensitivity, but this entity has to be explained, has to be understood. The reason why I'm saying that is it looks like there are many other conditions under this axis, this brain-gut axis. I think 22 have been named, which we used to call just functional disorders, from the upper GIT all the way down, functional what function, but these are disorders of the brain-gut axis, basically, which I think you, as you spend more time in reading, you'll understand these things. There are some people who are dealing with these classifications of Rome Foundation, global epidemiology issues. You see them when you read these things. Right, and then number 7 is this thing of gut microbiota. This altered gut microbiota is very important. Yeah. And then I wanted to say something about, I need to say something about FODMAP diet, and I will say something about the bile salts as well. I don't know where to start. Let me start with the easy one, the bile salts. We have primary bile salts, which are produced by the liver. Usually they start fresh. The name here, we have chenodeoxycholic acid and the cholic acid. These are primary bile salts. I think the only 2 which I know about. But they have to be conjugated to glycine, conjugated, or taurine. Then they have to travel from the duodenum all the way to the small bowel until they get absorbed in the duodenum. The relevance of this is this. If there are patients with small intestinal bacterial overgrowth, let's get that again. Small bowel intestinal overgrowth. They deconjugate those bile acids, all right. Then those bile acids do not get absorbed in that fashion in the terminal. They go over to the colon. Then they can cause diarrhea on their own right. So I'm just trying to say the bacterial overgrowth, which we can prove, on give antibiotics like rifaximin, that might improve because their bile salts are no longer available at the distal part of the bowel, large bowel, in this case. All right. So the physiology of the bile salts, I think, is important in the sense that it tends to intertwine with the gut flora as well, because certain microbiota, especially the bacteroids, are able to deal with these, especially the secondary bile salts, more than the firmicutes. So there's that interaction which I cannot go into now, but they feed each other depending on the either hydroxylation but don't worry about those words. There's hydroxylation, I know, to the bile acid, especially the secondary bile acids, so that they can behave differently. Because if they're hydroxylated, they become more water soluble. They won't be absorbed much into the colon. But if they are still unhydroxylated, they become more lipid soluble. They can go through the colon mucosa, and then they can cause trouble. But don't worry, that's physiology for now. So bile salts, they have to know primary, secondary, and then the gut microbiota, depending on which ones utilize this bacteria. You realize that patients after cholecystectomy, they do have diarrhea, but it's not long, it's not prolonged, it's not long. It will subside because the bacteria they adjust to that very quickly into this type of fresh bile from when there's no maturation in the gallbladder. All right, so I was trying to explain this, the importance of the bile salts and the importance of the gut flora as well. But now let's move to the FODMAP. I will put it to us that all the sugars are fermentable. All right, all sugars are fermentable. That is done by the bacteria in the gut. They are the ones which ferment and produce carbon dioxide, all right, and other acids, of course. And then the carbon dioxide, like you mentioned, can cause distension. Unfortunately, some acids can be of benefit to the colon mucosa, others might not be. For example, let me move back again. The monosaccharides, we know about them. The names we know. The disaccharides, we know about them. We should know about these oligosaccharides. Now, these are when the sugars become 3 or more than 10 to plenty, they're called now polysaccharides. There's oligo and poly, but it's still sugars, all right? And then the polyenols, what it means is that it's still sugars, 6 carbon, yes, but with a lot of hydroxyl groups. Too many hydroxyl groups now in these ones. They're called polyenols. It's very important. I'll give you the names here. There's mannitol, there's sorbitol, and there's xylitol. And there's also maltitol. I haven't heard about it. The mannitol, when it gets fermented by the bacteria in the gut, it forms butyric acid, right? And butyric acid, we know is good for the epithelium. And then the other ones like your sorbitol, I think it's worth mentioning that sorbitol is the one that when people are diabetic due to maybe low insulin type of thing, it's the one that is responsible for water in the lens where they cannot see properly. So it's a type of sugar which we do have and make, but this time we are still in the gut. So we know about sorbitol. I've told you about those things. These sorbitol stories and these sugars which I've told you about, but I've not told you about fructose, but it's a monosaccharide. All these things are found are used as food additives. So what I'm trying to say is that I'm suggesting actually that if you know this fermentation of sugars, and that to know that most of them are from food additives, if you advise patients to go fresh, like from the farm straight to the kitchen, they avoid these food additives because these are in excessive amounts which are not meant for natural human body consumption. Basically, that's why they get sick. But this is anecdotal, but I think it works for me. You're right. But I think I've tried to explain that all sugars are fermented, all of them. Fermented by whom? By the gut microbiota, depending on what is the source coming from, where it's coming from. I'll talk about another sugar here, which is very important, called lactose, you see. Lactose is a disaccharide, yes, from galactose and glucose. The thing is, these sugars, in human milk, the concentration there is around 5%. It's around that of the cow and the sheep and the goats slightly. But once you go into powdered milk that you buy from the shops, that is 50% lactose there. So if somebody's got issues with lactose intolerance, then I think exposing people to higher concentrations obviously make them sick. But if it's at lower levels, which I think related to natural environment, things are much better. Because I was trying to imagine if the Masai Mara people would be lactose intolerant, how it would be really. But okay, it's not IBS. I'm just saying that this addition of things can make things very difficult for us. Just remember, we're still in the sugars. These fermentable sugars will be given names like fructans and galactans. But basically, it's still sugars. There's nothing complicated about it. It's still these sugars which are fermentable, which are not easily absorbed, but fermentable. Because what I'm saying is, if they're not getting absorbed, bacteria work on them very quickly and produce those dangerous things. It's important that the galactans, as they put them, are found also in wheat, rye, and barley. I think this is very important. The reason why I'm mentioning those three is because there's something called gluten, which those three types of foods have. And I want to put it to ourselves that gluten is not a sugar. It's a protein. It's a huge complex. It's not a sugar at all. It's a huge molecule. Gluten is got glutenin and gliadin. The gliadin those are other types of protein which bind or put together this glutenin together. Then together it's called gluten. There are sulfur bonds bonding in there. Yeah, so it's big. That is big. It's got epitopes which when absorbed by the cell, that is, if there was a lack of some proteinases in the gut to get rid of that gluten or incomplete digestion of these rye, wheat, barley proteins, this gluten gets absorbed as it is, and it's not good for the immune system in the gut, inside the cells already. That's where you start having the denudation of the dying of these epithelial cells with time. So it's a time procedure. But I'm just trying to say, gluten is a protein complex structure which can be absorbed, yes, but the sugars are, it's something different. So I'm trying to, so that we can explain this things to patients as well, understand what's going on. So there should not be confusion between gluten sensitivity and IBS and FODMAP. Trying to put things straight here. So what else am I left with now? I think I've explained those mechanisms fully, and then I've explained your functional GI disorders. Now it's disorders of the gut-brain axis. Yeah, I need to, there's still time. Ooh, 2 minutes to go. Yeah, sorry about that. In the disorders of the brain, that axis, I think it's a requirement for us to understand the pharmacology. The pharmacology in terms of knowing about the serotonin and its receptors. I think there are about 15 of them, but it doesn't matter. We talk about 1 to 5, because 1, 2, and 5 are in the brain predominantly, but 4 and 5 in the gut. If you stimulate 4, you relax. If you inhibit 3, you get stop diarrhea. Basically, it's quite difficult to remember, but just know about that. We need to know about it, I think. We have to know about the cholinergic receptors, which is where we need to know which drug you choose for what, but what you should be comfortable with is the side effects of anything that you pick up. You need to know about the dopamine receptors, right? And the opiate as well, whereby you're talking about, I think you talked about the pyramid a bit, so that we know about that. In terms of SAML, I think can be a place. Opiate receptors, you have to know different types of receptors, mu, sigma, mu, and kappa, so you know exactly what you're talking about. We need to know about noradrenaline receptors, so that this is where these SSRIs will come into play, so that you can decide whether you are for them or you're not, based on how easy it is for you to handle them. All right. I'm not sure if I've talked about the other receptors which are important. Dopamine, histamine is one important one as well. You can decide whether to give somebody anti-H1, those drugs we mentioned there, being comfortable with what you want to give based on the side effect profile. Yeah, and then basically it's around the knowledge of pharmacology in terms of the receptors and knowing this gut microbiota stories and what's really happening down there, so that in the end, we're able to put the theory across to the patient. Because doing all this investigation, we can do them, but in the end, you're not going to be able to explain to this individual patient as to what's really going on if you don't have these, so that you know I'm choosing this for this because I'm thinking of that. And in the end, yeah, I think that is my contribution for now, unless there's something I'm missing here, because it's also something of my interest, this thing of irritable bowel syndrome, because it's very difficult. Yeah, I think you've covered everything around that, basically, so I'm happy. I think I understood everything, and it's very easy for me from here now to go and advertise that I know something about IBS. So thank you. Let me look for the comments, questions. I think I've answered number 1 already. Any association between IBS and SIBO? I thought I said something, isn't it, already? And then please excuse me. Oh, thank you. All right. Okay, with that, then I think I have to thank you very much. Thank you very much. Simon, well done. Thank you. I think I'm better off today. Let me see now. Yes, I have to thank everybody who was here. I think Vijay left early. I'm sorry about that. Thanks to ECO, University of New Mexico, and the ECO India team for this support. These recordings will be available on the Gastro Foundation website, I'm told. And then again, we have to thank the Gastro Foundation. Then I need to announce that next week, not in 2 weeks' time, next week, we're having something on constipation, fecal incontinence dysnergic disorders. Ooh, these are functional disorders again. Ooh, and by Dr. Aslam Parker and Prof. Mpokomo will be chairing the session. Yeah, and then, that will be next week. There's no harm to say that we will meet again next year on the 20th of January 2025, where we'll be now focusing on hepatology again for a good part of the year. And then Prof. Wendy's PMN, I think, will be the facilitator. So if there's nothing, there's nothing, because we are over time. So again, thank you very much. Simon, well done.
Thank you very much.
I'm going.